Good afternoon, everyone. We're going to give it about 15 more seconds to let people join, and then we'll get started. Okay, good afternoon. So you guys are all the diehards. This is the last lecture of the seminar, I guess. Good afternoon again. My name is John Ingram. Today's presentation is going to be, can you really die of a broken heart? And I have no disclosures with this lecture. All right, my slides are not advancing. Here we go, okay. So the day is May 24th, 2022. It was a Tuesday. The place, 80 miles west of San Antonio, sits a small town of Uvalde, Texas, population 16,000. At 11:30 a.m., a young man entered the Robb Elementary School in Uvalde, Texas, and began shooting, killing 19 students and 2 school teachers. One of those school teachers was Irma Garcia. She was 48 years young. 2 days later, just 48 hours later, her husband, Joe Garcia, 50 years young, suddenly died of a heart attack. A Garcia family member was quoted as saying, "I truly believe Joe died of a broken heart." Can you really die of a broken heart? Is such a phenomenon real? The dates, the years 1987 to 1989. The place, mainland China. From 1987 to 1989, over a 3-year period, there was a series of 7 earthquakes that hit mainland China. Doctors noticed that shortly after each earthquake, there was a flood of admissions to the emergency department where people were complaining, otherwise healthy people, were complaining of what seemed to be acute coronary syndrome with left ventricular failure, but it was in the absence of coronary artery disease. Dr. Sato was the first to describe what he called takotsubo. Dr. Sato and his colleagues, in a published article in Japanese at that time in 1990, is credited with describing this phenomenon that he called takotsubo-like left ventricular dysfunction due to multivessel coronary spasm. At that time, they did not understand what was causing these otherwise healthy adults to come into the emergency room following these earthquakes, but they believed it was due to multivessel coronary spasm. It turns out that was not the case. But then he again published it in the Journal of Cardiology 1991 in English and titled the article "Myocardial Stunning Due to Simultaneous Multivessel Coronary Spasm," a review of 5 individual cases. Again, he assumed that it was being caused by some type of coronary spasm. We now know that that was not the case. We're going to talk on this lecture or cover what is Takotsubo cardiomyopathy, or also known as heartbreak syndrome, what causes it, how does it present, how do the people who with this syndrome present themselves into the emergency room, who does it most commonly affect, how frequent is it, the pathophysiology, and the treatments and the prognosis. So let's first talk about what is it. It is a stress-induced cardiomyopathy that mimics acute coronary syndrome. People think they're having a heart attack. It's characterized, though, by transient dysfunction of the left ventricle with a distinct apical ballooning, which we're going to discuss. But the patients have patent coronary arteries, and there is no evidence of coronary spasm. And also, the differences between a heart attack or acute coronary syndrome is that there's minimal elevation in their cardiac enzymes, sometimes no elevation in their cardiac enzymes. When you look at the imaging of this on a screen, you see on the left side, that's an image of someone with Takotsubo cardiomyopathy. And there's end diastole. And then when you see end systole, it's a very peculiar shape of the left ventricle. And Dr. Sato and his observation of this syndrome said, the ventricles look like a takotsubo pot, which is an octopus trap pot used in Japan. And as you'll notice, you have an apical ballooning there, but what you have is a compensatory constricted area of the outflow tract. And this is why he thought it mimicked the shape of the octopus trap that they use in Japan. Now, what causes this? Takotsubo cardiomyopathy is typically preceded by exposure to emotional or physical stressors. Doesn't have to be emotional, as it turns out, but such as an unexpected death in the family, some type of physical abuse, emotional abuse, a quarrel, some type of severe, exhausting physical work can cause it. And that in some cases, precipitant stressors have not been able to be identified. Dr. Yubari and his colleagues published an article back in 2019, the Journal of American Heart Association, short and long-term prognosis of patients with Takotsubo syndrome based on different triggers, the importance of the physical nature. And he looked at 939 patients with definitely diagnosed Takotsubo cardiomyopathy, and he discovered that 340 of those, or 36.2%, did have an emotional trigger. 293, or 31.2%, had a physical trigger, meaning some severe physical exertion brought this on. No trigger could be identified, though, in 306 of the patients, which was 32.6%. When you talk about the main triggers, the main physical triggers, these vary, and what they included were 30.7% were infections, 22.5% have had them after a surgical procedure, 18.4% from severe physical activity, 18.4% from episodes of severe hypoxia, and just under 10% from a neurological event, such as a TIA or a stroke, could also bring on this type of cardiomyopathy. Now, interesting, they believed it is due to a severe rush of epinephrine and adrenaline in your system, and they were able to duplicate this. People have been able to duplicate this in other studies. In cases of pheochromocytoma, which as a lot of you know, is a tumor of your adrenal medulla, which causes severe secretions, increased secretions of epinephrine. They've also seen it when people have used an EpiPen and got a lot of injection, a high injection of epinephrine because of an attack of vasoconstriction in the respiratory system, and they an allergic attack, and they've seen this cardiomyopathy in those patients as well. So they're able to replicate that for short periods of time. How does it present? The most frequent clinical symptoms of Takotsubo cardiomyopathy on admission are chest pain, dyspnea, resembling acute myocardial infarction. The ECG findings often include ST elevation with T wave inversion and Q wave formation. So the ECG findings themselves are actually insufficient to differentiate between acute anterior MI and Takotsubo cardiomyopathy, which is why it's many times misdiagnosed. Takotsubo cardiomyopathy can develop in men and women of any age and any ethnic background. However, 90% of the cases are women, and 80% are postmenopausal women over the age of 50. When it does occur in men, however, they are 90% more likely to die from this syndrome than women. Broken heart syndrome is surprisingly common. 2% of the people that are hospitalized with a suspected heart attack actually have Takotsubo cardiomyopathy. And if you consider that 735,000 Americans who have a heart attack each year, 2% would mean that 14,700 people actually see this syndrome every year in our country. The condition overwhelmingly affects women ages 58 to 75, likely due to decreased levels of heart protecting estrogen. In response to sudden, unexpected, severe emotional stress, okay, when we look at the pathophysiology, it's in response to a sudden, severe emotional distress, which causes marked increases in the sympathetic neuronal and adrenomedullary hormonal outflows. Epinephrine release from the adrenal medulla and norepinephrine release from sympathetic nerves stimulate the heart and blood vessels. Within the heart, high circulating levels of norepinephrine and epinephrine, along with increased release by the sympathetic nerves, induce catecholamine toxicity and hypercontraction of the ventricles. Also, contraction of the arterioles increases blood pressure and also increases cardiac afterload. Hypercontraction of the left ventricular outflow tract results in increased mechanical wall stress in the left ventricular apex. So these disturbances in the coronary microcirculation, which are also accompanying this, along with an increase in the oxygen demand, of course, of the cardiomyocytes, this triggers oxidative stress, which creates a positive feedback loops that lead to stunning of the apical myocardium. Now, we're going to look at this in just a second, but the working hypothesis is that in postmenopausal women, the loss of estrogen exaggerates the responses of the central neurons and cardiac cells and reduces the production of cardioprotective substances. So when we look at this on a diagram, we start off with emotional stress, which directly affects the hypothalamus. The hypothalamus then stimulates the medulla to release inordinately high amounts of epinephrine. This then causes the sympathetic excitation of our nerves, which releases high amounts of norepinephrine. So between the epinephrine and the norepinephrine, you have high alpha, which is going to cause vasoconstriction of our blood vessels, but then the hypercontraction and the beta response causes hypertraction and obstruction of the LV, left ventricular outflow. So the outflow tract tends to overcompensate with enormous hypercontraction. So between this high levels of epi and norepinephrine being released, we have a catecholamine toxicity, which leads to increased oxygen demand, mechanical wall stress of the left ventricle ensues, and you end up having a hypocontraction of the LV apex, which eventually results in an apical ballooning out of the left ventricle, which is synonymous with this syndrome. So when you look at the people and the postmenopausal women with reduced estrogen, they end up producing lower amounts of nitrous oxide and lower amounts of something called HSP70 and ANP, which these all three items are very cardioprotective. And in normal estrogen levels, they have this protective substances for cardiac situations as this. But without the reduced estrogen, they are less cardioprotective. And this is what they believe is going on. Well, regard to treatment, there's really no standard accepted treatment for Takotsubo cardiomyopathy. Most, however, fully recover within about 30 days as their distress and stress over the situation begins to subside. It is controversial to prescribe beta blockers. Some people have tried beta blockers to try to block the excessive catecholamine response. And it's controversial because it has been very controversial to note that it has any improvement on survival. And actuality has caused severe arrhythmias to occur as well. Research has shown that ACE inhibitors to treat high blood pressure may improve survival. The management of the disease, though, is mostly centered on symptom control and prevention, such as supportive therapy. Patients that develop heart failure are usually treated with diuretics and vasodilators to decrease the blood pressure. Fluid resuscitation and possible intra-aortic balloon pump may be required in those that develop cardiogenic shock. Anticoagulants might be considered to prevent thrombus formation in the left ventricle because you could have some stagnation occurring there in the apex of the left ventricle with that ballooning out. But addressing the emotional and physical stressors are important factors to consider as well. Now, there is one paper that I researched, and there is a proposed treatment that if you wanted to zero in and say, how would I actually treat this patient? One proposed treatment that seems to work fairly well is keeping the patient in an upright posture, giving them oxygen, and instead of beta blockers, giving the patient magnesium sulfate for the prolonged QT interval and the occasional VTAC that they sometimes experience. If pulmonary edema ensues, diuretics, sedation, and maybe morphine would be appropriate. But then long-term estrogen treatment may be prudent in postmenopausal women who have suffered an episode of Takotsubo cardiomyopathy. Now, in a paper by Alashi and his colleagues, Characteristics and Outcomes of Patients with Takotsubo Syndrome, Incremental Prognostic Value of Baseline and Ventricular Systolic Function, this was published in 2020 in the American Heart Association Home Journal. But they sought to determine the long-term outcomes in patients diagnosed clinically and angiographically with Takotsubo syndrome. They looked between the years of 2008 and 2006 and 2018. They studied 650 patients. Their age ranged from 66 plus or minus 14 years. 88% were women and 12% were men. The primary endpoint was all-cause mortality. Now, patients with physical triggers, they found, was 41%. Patients with unknown triggers, 34%. Patients with emotional triggers was only 16%. And patients with neurological triggers was 10%. 94% of the patients, though, had an ejection fraction less than 52%. 80% of the patients had that apical ballooning that I had demonstrated earlier. None of the patients had coronary artery disease. 175 patients, or 27% of the patients, died in the first 30 days of getting Takotsubo cardiomyopathy. Patients with a neurologic or physical trigger, though, had a significantly worse survival rate, and patients with an LV ejection fraction less than 38% were associated also with a significantly worse survival. In conclusion, Takotsubo may be an effort by the body to avert the worst consequences of a massive adrenaline surge by switching signaling to a protective mode. The heart is temporarily shut down to prevent a worse outcome, and maybe this protective pathway is active in most of us, but in a less dramatic form, to save us from the effects of sudden stress. For instance, during panic attacks, people can report feeling as if they're having a heart attack, but this quickly wears off as they recover. Estrogen is a powerful protector against arrhythmia, and younger women seem less likely to get broken heart syndrome. Perhaps the risks from the physical and emotional stress of labor and birth has led to an evolutionary protective mechanisms against adrenaline toxicity in fertile women. Women in the menopausal range will have decreasing levels of estrogen, but still have residual levels. Perhaps they are moving from the protected status of the younger women towards the more vulnerable male situation. Men are 90% more likely to die in the first 3 months after bereavement, but for women greater than 50, this figure is only 50%. So yes, you can die of a broken heart, but your risk depends on both your sex and age. Perhaps then the better question remains, if you can die of a broken heart, why are so many of us spared? And I thank you for your attention and thank you for listening. Let's see if I can get the chat up here. Okay, we'll go to the chat. I have the chat open if anybody has any questions or comments. See, there's a Q&A here. Okay, we have a Q&A here. Postmenopausal women who recently lost their parents. I was wondering about the chest pain I was getting. Okay, this talk was very interesting. Thank you so much. Okay, I think we don't have any more questions in the chat or in the Q&A. Thank you guys for listening.
Mhm.